Hello, for our project we chose to look at the use of video monitors or sitters for patients at the risk of falls.
In patients at risk for falls, does the use of safety companions compared to remote video monitoring provide a greater reduction in injuries?
The system currently in use utilizes a 360-degree camera with night vision capabilities. The operator is also able to communicate with the patient. The video monitor tech is able to monitor 7 patients at once.
Patients must be able to be redirected by voice command. Patients on suicide precautions do not qualify for video monitoring. Patients who are violent towards staff also do not qualify for video monitor system. More than 3 redirects in a single shift requires that the patient have a safety companion in the room.
Reasons that hospitals have increased video monitoring include an increase in falls system-wide, budget restraints and limited staff, and trying to better utilize current staffing levels. Here is the search criteria we used when researching our topic. These are the search terms that we used. The first article we used was about a program that aimed to reduce sitter use through mobile video monitoring. The information on this slide was found using the evidence appraisal tool. The study found that use of video monitoring to replace sitters kept fall rates at or below national figures. Additional findings showed that by reducing need for sitters, there was more staff to help care for the patient population as a whole. There was also a documented reduction in staffing cost across the hospital. Our second article was about a sitter reduction program in an acute healthcare system. This information was found using the evidence appraisal tool. This program was implemented system-wide. It also included widespread changes that included renovation to rooms and transitioning sitters to PCA positions. The study did not, however, mention the use of video monitoring. Research performed prior to the study found that safety companions did not prevent falls. Cost estimates for safety companions were difficult to achieve due to the various roles of the personnel used.
Estimated cost savings in the system was $1.2 million. There were no job losses due to position changes, and there were more staff being used as PCAs. Our third article is about video monitoring for patient safety. The information that we gleaned from our article appraisal tool is as follows. The purpose of this study was to evaluate the effectiveness of continuous video monitoring. The study found that staff was better able to be spread around for more patient care. Not all falls can be prevented with video monitoring. Patients who are impulsive cannot always be stopped in time. Other limitations include patients with communication issues. In-room sitters are very much more effective for certain patients.
Use of video monitoring at our facility was similar compared to our research articles, although not every article set specific guidelines to how they used it. In addition, research performed at our facility prior to implementation is not known. In contrast to some of our articles, our clinical site did not completely eliminate the use of sitters. They also did not do any physical remodeling to the rooms or the site. The use of video monitoring was also implemented system-wide as opposed to just several trial units.
When following clinical best practice, use of video monitoring in comparison to safety companions provides a greater reduction in falls and related injuries while reducing staffing needs and expenses. When patients fall outside these guidelines, violent, suicidal, hard of hearing, redirected 3 or more times, use of a safety companion is best practice.
The positive outcomes should be a reduction in injury from falls when following EBP guidelines, also reduction in staffing costs and needs, better utilization of current staff, and better implementation of video monitoring technology.
Thanks for watching our presentation.